Hey everyone, welcome back to the channel. Today we're going to talk about antiarrhythmics, and specifically we're going to talk about how antiarrhythmics affect ventricular myocytes and our pacemaker cells, and the classification system that's used for antiarrhythmics as well. To begin with, let's just revise what we know about the pacemaker cell and the ventricular myocyte action potential. So on the left here we have the ventricular myocyte, and on the right is the pacemaker cell in blue. To orientate ourselves to this graph, on the y-axis is our membrane potential in millivolts, and on our x-axis is time in milliseconds. At the bottom here I've drawn a green line, and this is to represent our cell wall, and anything moving in or up is ions moving into the cell, and anything moving down is ions moving out of the cell. Everything in red represents our myocyte, and in blue represents our pacemaker cell. So as you can see here with the ventricular myocyte, you have a resting membrane potential, which is about -90 millivolts, and that's our phase 4 of the ventricular myocyte action potential. And this is maintained by sodium-potassium ATPase, which moves 2 sodium out for 1 potassium in, so it maintains this negative membrane potential around -90 millivolts. Then when stimulated by, for example, a pacemaker cell or electricity, you'll have voltage-gated sodium channels that open, leading to an influx of sodium, which is usually higher outside the cell compared to inside the cell, which leads to rapid depolarization to about +50 millivolts. These sodium channels then close, and this marks the start of phase 1, which is dominated by potassium efflux, and you can see that your membrane potential becomes more negative as potassium leaves the cell. This will continue to decline except for that you have these calcium channels that open, and the sarcolemma of the myocyte also releases calcium into the cell. So this is freely available and leads to your contraction coupling that occurs, leading to contraction of the ventricular myocyte. But for the action potential, what this does is it maintains a plateau phase of about 20 millivolts. And you can see here that between depolarization and the end of this plateau phase is about 250 milliseconds, and this is the absolute refractory period where another stimulus that comes through will not stimulate the ventricular myocyte. Once these calcium channels close, phase 3 starts, and this is dominated by an efflux of potassium outside of the cell. And this is about 50 milliseconds and is the relative refractory period. So if you get another stimulus that comes through somewhere in this period here, it could potentially lead to another depolarization of the cell. After phase 3, we go back to phase 4, and again, this is essentially just resting membrane potential, which is sodium moving out and potassium moving in due to the sodium-potassium ATPase. Now, if we talk about the pacemaker cell, this is very different, as it has a phase 4, and phase 4 also has sodium out with potassium in through the sodium-potassium ATPase. However, the membrane is quite leaky to sodium, and you have what's called the inward funny current, which leads to this constant leak of sodium into the cell, which means that you have this unstable resting membrane potential that's constantly going positive until it reaches threshold and enters phase 0, which, unlike the ventricular myocyte, where phase 0 is dominated by sodium influx, phase 0 in the pacemaker cell is dominated by calcium influx. So this phase 0 will then reach a peak at about 20 to 30 millivolts, where the calcium channels will then close and potassium efflux will dominate. So potassium is leaving the cell, making the cell more negative. We then reach our bottom of our membrane potential, which is dominated by our sodium-potassium ATPase, plus our funny current here, that leads to the leakiness of the sodium with our membrane potential becoming more positive. And it's this angle of phase 4 in the pacemaker cell that causes automaticity within the pacemaker cells, meaning that they'll fire at the rates depending on the leakiness of the sodium channels. So for example, the SA node is quite leaky to sodium, so you have a automaticity or an intrinsic rhythm of about 100 beats per minute, while the AV node sits more around the 60 to 80 beats per minute. So I talk about this more in my specific videos where I mention our fast response action potentials and our slow response action potentials, which I've linked down in the description and in the comments. But the video is more about the anti-arrhythmics and the classes anti-arrhythmics, which you can classify using the Vaughn Williams Classification. So there's 4 classes in the Vaughn Williams Classification, and the way I remember the classes is through the acronym some Block Potassium Channels. So let's just zoom in on this. Now, when we're talking about the different classifications, I mentioned 4 of them. So the first one is class 1, and the first word starts with an S, so it's for sodium channel blockers. And this can be further divided into class 1A, 1B, and 1C. And the way it's broken up into these classes is based on the binding kinetics of the drug to the sodium channel. So class 1 has intermediate binding kinetics. 1B has fast binding and dissociation kinetics. And 1C is slow. Another key feature is that our 1A drugs also have some potassium channel blocking effects as well. Now for class 2, this is a bit easier. It's our beta blockers. Class 3, as per the acronym, is potassium channel blockers. So put a K here. And then lastly, channels has a C, and this is for calcium channel blockers. And these are your 4 classes of the Vaughn Williams classification. Sometimes you'll run into other classifications where they mention a 5th class or an others class. And these are drugs that don't particularly fit into each of these classes, such as magnesium and digoxin and other medications that also have antiarrhythmic properties but don't fit into our class structure for the Vaughan Williams classification. So if we come back to our graph here and we look at where each of these different medications affect either the myocyte or the pacemaker cell, if we start with our sodium channel blockers, we can see that in our ventricular myocyte, the depolarization period is dominated by sodium channel influx. For our pacemaker cells, there's our normal sodium potassium ATPase, but there are these special sodium currents for the funny currents, which aren't particularly affected by our sodium channel blockers. These ones, just for interest, there is a specific drug that affects the funny current, and this medication is called ivermectin. And that's all you really need to remember, is that this medication affects the funny current, which changes the angle at which the cell's automaticity is. So it actually makes it a little bit less steep, meaning that if it's steeper, you'll get a slower heart rate. So it slows the heart rate down. But if we come back to our sodium channel blockers, and if we were to talk about our 1A agents first, and this includes things like quinidine and precanamide, if I were to superimpose the way that they change the ventricular myocyte action potential, it would look something like this. So I'll draw it in grey here. So you'd have your standard plateau phase. Then because you're affecting the sodium channel, you'll actually get a shallowness, so a slowing of our depolarization. So it changes the angle here. You still get to plateau because remember these aren't affected by our sodium channels. And then interestingly, our class 1A have some potassium channel blocking effects that prolong our phase 3 as well and brings us back down to our plateau or our resting membrane potential at phase 4. So as you can see here, we have a shallower depolarization, and our class 1A medications have some potassium channel blocking effects, so you actually do get a slowing down of our brief repolarization period before we hit the plateau. Then our calcium channels are open, so the plateau's there, and then our phase 3 is slowed because of the potassium channels that are also blocked. And then we hit our normal resting membrane potential. So these medications are quite interesting because if you prolong your plateau period and your repolarization time, you actually get a QT interval that prolongs, which makes sense because the QT interval is from essentially the start of depolarization to the start of repolarization. And although these are anti-arrhythmics, they can be pro-arrhythmic because of their QT prolonging effects. And you can open up risks such as Torsades de Pointes and other types of ventricular fibrillation. They also have a use dependence block effect, meaning that they're more pronounced in tachycardia because of the slower dissociation from the binding site in diastole. Now, if we go to our 1B antiarrhythmics, and I'll use purple for this one. Now, 1B don't have any effect on the duration of phase 0, so you actually have the same upslope, essentially, and then you get your normal potassium channels that open here and hit a plateau phase, and then a normal duration here for your plateau before you hit your resting membrane potential. So these medications are things like lidocaine, which is a sodium channel blocker, and mexiletine, which is another type of sodium channel blocker used in more advanced cases where you're trying to treat arrhythmias. And these ones have fast binding and fast dissociation. And they have a use-dependent fashion as well. So the faster heart rates they have more effect on because the sodium channels are opening more often, which you see in local anesthetics such as lidocaine when it's used peripherally on nerves. And importantly, because you don't have a change from your depolarization to repolarization, they don't prolong your QT interval. Now, if we go for our 1C antiarrhythmics in our Vaughn Williams classification, they change the shape of your ventricular myocyte action potential as they have a prolonging of the phase 0. So our phase 4 again is flat, and then phase 0 is prolonged, but they don't increase the length of your plateau and repolarization period. And they hit phase 4 normally here. So these medications, such as flecainide, they lead to this prolonged phase 0. You have your normal plateau and then a normal repolarization, so they don't prolong the QT. But because of this prolonged phase 0 that happens here, you do have a widening of your QRS complex with these medications. So there's increased QRS duration, which can lead to pro-arrhythmic effects with them again as well. Now moving on to our beta blockers. And beta blockers are a bit different in that they don't necessarily affect your ventricular myocyte. What beta blockers do is they reduce the adrenergic input from things such as adrenaline, noradrenaline on the heart. And adrenoreceptors in the heart lead to intracellular changes and signaling. So for example, if you bind up your beta-1 receptors in the heart, you get increased cyclic adenosine monophosphate, which leads to downstream signaling, meaning that you get increased sensitivity to your sodium funny currents. So you get increased sodium leaking into the cell, which increases the steepness of this phase 4. And if you have increased steepness, you reach threshold quicker. So for example, if threshold is here and you have a steepness, you hit threshold there, meaning that you will then depolarize. And then by the time you get here and you have increased steepness and you hit threshold again, you have another action potential. And then again, it happens again, meaning that you have a faster heart rate. So if you're a beta blocker, what you're doing is you're actually down-regulating this cyclic adenosine monophosphate because you're blocking the beta-1 receptor. And what this does, if I draw it in green, is it decreases the steepness of phase 4. So when you reach threshold, which is about here at about -40, -50 millivolts, you then trigger your calcium channels, leading to a depolarization. And by the time you reach the bottom, you then have this more shallow angle here, meaning that you have a slower heart rate. So they slow the heart rate down. And these kinds of medications, if you want to talk about cardioselective beta blockers, you can remember it with the acronym BEAN, which is bisoprolol, esmolol, atenolol, nebivolol, and then metoprolol is the other one. And these medications all slow the heart rate down to help reduce any signaling going through your AV or your SA node that might be stimulating an arrhythmia. Now, if we move on to our potassium channel blockers, and potassium channel blockers, interestingly, are things such as sotalol, which you would otherwise normally think is a beta blocker, but it's initially a potassium channel blocker and then in higher doses becomes a beta blocker. And another one that's sometimes classified into class 3, but actually is in many different classes, is things like amiodarone. Now, potassium channel blockers are interesting. I'll use pink here because what they're going to affect is this part, so phase 1 of the ventricular myocyte, and they're also going to affect phase 3 because remember these are dominated by potassium. So essentially what they're going to do is they're going to prolong your repolarization times. So when you get to phase 1, you're going to have a slower repolarization and you're going to get a slower repolarization of phase 3. And we mentioned before about how, if you change the time from depolarization here to repolarization here, you're going to prolong your QT interval. So again, they can be pro-arrhythmic in the way that they block these potassium channels. They will actually prolong your QT interval. But because of them increasing your absolute and technically your relative refractory period here, they have an anti-arrhythmic effect in that they can break the pro-arrhythmic source by slowing down the way in which the ventricular myocyte can actually repolarize, because the longer it takes to repolarize, it will spend more time in the absolute refractory period, which is about to here, and in the relative refractory period, which is to here. Now lastly, we'll talk about our calcium channel blockers. And calcium channel blockers can be divided into dihydropyridine, which are usually selective vasodilators, and non-dihydropyridine calcium channel blockers, which will be the ones that affect the heart, and they can be further broken down into benzothiopein and your phenylacrylamine calcium channel blockers. And your benzothiopein ones is diltiazem, and your phenylacrylamine ones is verapamil. And they affect the pacemaker cell, and you can demonstrate this. I'll use orange here. As the pacemaker cell, we can see here that depolarization is dominated by calcium influx. So what it does is you have your normal threshold reached, but you slow down your depolarization, which you can see means that you will have a slower heart rate. So that summarizes the video. We've talked about our antiarrhythmics. We've explained the Vaughn Williams Classification of antiarrhythmics with our 4 different classes and our class 1 broken up into 3 classes. We've discussed how each of these affect the ventricular myocyte and the pacemaker cells. And just to summarize, our sodium channel blockers affect ventricular myocyte, beta blockers affect pacemaker cells, potassium channel blockers affect ventricular myocytes, and calcium channel blockers affect pacemaker cells. And then we have our other medications which don't fit within the Vaughan Williams classification, and they can affect different parts, either the ventricular myocyte or the pacemaker cell. If you have any questions, anything you want to add, anything you want me to cover, feel free to leave it in the comments, and I will try and follow this up and make a video about whatever you want to see.